Thank you very much. Our we're going to cut into our lunchtime a little bit so that we can continue to have the speakers and then some discussion. Our next speaker is Dr. Stacy Fischer, who's an associate professor of medicine at the University of Colorado. She has marshaled a very unique approach to a population, an identified population in need, and I think speaks to what I was talking about by saying, look at the innovation, look at the passion for the solutions that we all have to come up with in our individual communities.
So a few disclosures. In addition to having no financial disclosures, I do have some other important disclosures. I have been working for 15 years within the Latino community, yet I am not Latino. And while at one time one might have called my Spanish conversational, at this point, I don't use it as often, and I probably have the language skills of a precocious 6-year-old in Spanish. And the other important thing is, I want to say, as we're talking and building on what everyone has said and shared, bringing in cultural values and integrating these into care is very important. But in the full disclosure of cultural competence, cultural humility, that these are starting points of conversations. And so that what I'm going to present to you today is a start of our conversations with our patients, but yet don't mean this to be a new cookie cutter approach or a new silo to care. And I'm also a very concrete person, so I'm going to present my research in a fairly concrete way as examples of how this can be done and how we've been able to do it. So starting with the case, this is Mrs. A. She's a 68-year-old Latina woman. She speaks mostly Spanish, a little English. She was admitted to the hospital in an acute pain crisis. Turns out she has recurrent metastatic breast cancer, and she is the caregiver for her 3 grandchildren who live in their home, and she doesn't like the way the medications make her feel sometimes. They cause constipation, they make her a little fuzzy, and so she tends to take them just kind of when she wants to, and is always sort of responding to a crisis rather than being proactive about it. And a lot of that has to do with communication gaps that have been an ongoing problem within the oncology clinic where she is seen. The other issue that came up is that she's now on 3rd-line chemotherapy for her cancer, and she's tired of it. She expressed that she no longer wants to do it. The side effects were very debilitating, and that she did not feel like the chemotherapy was helping her anymore. And so what she would do is stop coming. So she missed a number of appointments and then was admitted in a pain crisis. She was delirious upon admission. She had no decision maker in her chart, and her family did not want to talk about hospice initially. So this is the kind of case that is all too typical and really is a starting point to think about the work that we've been doing. And so it's exciting to see that a lot of people and organizations that help fund this work in the very beginning are here and present in this room. How did we integrate the voice of our patients, their families, and the community into what we were doing? This is one slide that represents about 7 to 8 years of work, looking at a long observational study where we talked to hundreds of patients across different care settings, community care settings, VA hospitals, safety net hospitals, academic medical centers, to get the entire representation as best as we could, at least in our community in Colorado, of ethnicities, of access to care, of socioeconomic status, and education. We conducted focus groups in community settings, within patient centers and clinics. We talked to a lot of key informants and had a lot of stakeholder panels to help us say what is important, what do we need to know in the context of serious illness for this community. So what did we learn? We learned that there were some serious gaps, not surprisingly, but specifically the areas of focus that came up again and again were around advanced care planning. One little piece of information we learned, there was a huge gap in understanding. We talked to patients who were admitted to the hospital within 24 hours of admission. So theoretically, they all should have been counseled on their advanced care planning, right? So what we found, though, there was a tremendous disparity. And it turned out that the Latino patients were much less likely to understand what an advance directive was, what it meant, or to even report that anyone had ever even mentioned it. And then the other kind of interesting disparity that we've also found was that when they did understand, they were actually more likely to have completed one. So that was an interesting finding, and we knew we had to incorporate that into our interventions. Pain management, we found very interesting interactions between income and ethnicity. The poor, meaning incomes less than $15,000 a year, Latinos were more likely, 100% of Spanish speaking were likely to report satisfaction with pain management. Where when we talked to Latinos who had incomes that were reported higher than $30,000, only 20% were likely to report satisfaction with pain management. We found the opposite pattern in the Caucasians. So we were kind of thinking, what is going on here? There's some kind of disparity. When you look at the subjective reports of pain on a scale from 1 to 10, what is your pain? It's about 4.5 across the board. No differences. So clearly people's experiences, perspectives, and expectations were different, and we needed to address that. Hospice. When we talked to some of our Spanish-speaking focus groups about what hospice meant, they said, oh, no. That hospicio, not a great translation, it's an orphanage. It's an insane asylum where you drop off the person that you love because you can't take care of them anymore, and that's just where you leave them. It's a nursing home. Whatever we found was so far apart from what the reality was, that we have this wonderful option for people where we can integrate the family, where the family is taking care of patients in their home, yet that's not how it came across. And so we knew we had to incorporate that as well. We found core values that came up throughout the conversations that informed what we did. Familia, family. This was an incredibly important thing. It came across in every aspect of care. The importance of confianza, of trust, so that the patients had to be able to trust the provider and had to know that they were on their side. Personalismo, a pamphlet was not going to do it. That this one-on-one connection with their provider is what allowed them to have these conversations, and it was very important to them. And it wasn't just about a clinical encounter. It was about establishing rapport. It was about finding connection. And then a barrier, fatalismo. Well, this is what it is. This is going to happen. And if maybe I start talking about it, it might even make it happen sooner. And so that was an important aspect of care that we had to at least be able to think about and talk about. And then we did additional cultural tailoring to all of our materials. So making sure that at the very surface level, we were handing brochures that had pictures of patients that kind of looked like the patients that we were working with. But then at a deeper cultural tailoring level, making sure that these core values were also incorporated into everything that we were doing. And that led to our intervention. And as I mentioned, we had the help of community advisory panels, stakeholders, and experts, and they really helped us with every stage of planning. Our intervention is called Apoyo con Cariño, which roughly translates to support with caring. And it was a patient navigator intervention to improve palliative care outcomes for Latinos with advanced illness. And if anyone is familiar with the work of Dr. Freeman, who used Navigators in Harlem to increase rates of breast cancer screening in women, we took that same approach and said, we need to find people from the community, who are of the community, who are bicultural, bilingual, who can establish that relationship of trust, that personalismo and confianza with our patients to help them through this very difficult time. And so we had two important questions. The first one, can it be done? And then, does it actually help patients and their families? And so to answer the first question, can it be done? We found it was indeed feasible, that patients and their families reported high levels of satisfaction with meeting with our navigators. And then we had to tackle the bigger question is, can this actually help? And so I'm going to review the results of our study that was funded by the American Cancer Society. We conducted a randomized controlled trial of 223 Latino adults who all were over 18 and had some form of advanced cancer, solid tumor stage 3 or 4. Our control group received our culturally tailored, linguistically appropriate materials in their whatever language they preferred in that covered those domains of interest that I mentioned, the advanced care planning, pain management, and hospice care. Our intervention patients got the same materials and then 5 home visits with our patient navigator to go through these palliative domains in more detail. And as I said, all the visits were grounded in Latino values. They were all developed in partnership with our community advisory panel. And the scripts were flexible. So if a navigator went into a patient's home and said, I'd like to talk about hospice, and the patient says, I'm not ready to talk about hospice today, said, that's okay. We're going to put it aside for right now. I want you to know that I'm available to talk about it whenever you're ready. And so here are some of the examples of the written materials we used. Now, some were widely commercially available, like on the far left. That's published by Channing Bett. Very simple language, appropriate for patients of low literacy, with illustrative pictures and bulleted text. We also had generously, who you'll hear from later today, we're able to use Dr. Sidori's advanced directive, again, validated in English and Spanish, and specifically tailored towards a low literacy audience. And then when we started looking at pain brochures, we really struggled with this one, and all we could find that was sort of out in the literature sort of had pictures of old white men. And we thought, well, this is not going to work with our community. And so we decided we'd develop our own. And as you can see, there are some examples of both that surface level cultural tailoring. Do the pictures look like our patients? But then also the deeper structural tailoring, where when you have your pain controlled, you can help with your family and take care of your family. So incorporating that core value into every aspect of what we were doing. And then I just have to give a shout out to our wonderful navigators. They represent different areas of the state of Colorado. Alamosa is down in the sort of middle south, representing some of the poorest communities in Colorado, poorest counties, and the most diverse counties. So about 50% of some of the counties around the San Luis Valley area are Latino. Diane is on the western slope, and Claudia was in Denver. None of them have a professional health background. They've worked in healthcare and research at one point or another in their lives. They're all bicultural and all bilingual and all in that community. So when we would go down to visit Rose in Alamosa and we walked into one of the little family-owned restaurants, everyone's like, Rose, hi. You kind of felt like you were with rock stars when you're with these navigators in their communities. And we could see why that was so important. Because while this looks like kind of a generic standard accrual table from any kind of study, it really represents, I think, the heart and soul of what we're talking about today, which is integrating that patient and family and community voice. So we had 318 patients referred. That was about 75% less than what our sites thought they might have as eligible patients. And so we worked with them. We made so many trips down to Alamosa, so many trips out to the Western Slope to engage with our communities, to engage with the healthcare providers down there, to tell them that they were really important to us, that the study was important to us, at every level, not just our navigators, but at the PI level, at the co-I level, that we really came as a team and worked with them. We had 223 patients enrolled and randomized of those 318 referred. So when you take out those who were ineligible, that represents an almost 80% enrollment rate, which is really exciting. And then when I think about how did we accomplish this, one is our navigators. That's probably 1 through 10, our navigators. They were fantastic because they could speak the language, because they could connect with the patient. But we also had strategies that I think, to build on what Shanta was mentioning, transportation. Our navigators actually did home visits, and they did those consenting visits at home. And sometimes they did those consenting visits at home on weekends and at night, when patients or their family members who might be working could be available to also participate. So we had incredibly flexible navigators who addressed that major barrier. And we also worked with community centers. So a typical cancer clinical trial is out of an academic center. And so you're going to get a certain kind of patient that is seeking an academic level of care. You're not going to get rural communities and patients being served in their rural communities. And so by going out and engaging these different sites, we were able to capture a more diverse audience and participants. And then, of course, the language and the materials going through. I love the recurrent theme of ask, tell, ask. We use those same strategies within our consent forms to ensure that we really had informed consent. I was reading something recently that it was on the order of 60% of parents of children who are involved in clinical trials did not understand that their child had been randomized following the clinical trial. We wanted to be very certain that our patients were engaged and informed at every aspect of our study. And then, as you can see, following the table down, we lost very few to follow up. Our navigators were so talented at building rapport and working with our patients. It was really rewarding. This is just our demographics of those 223 patients. You can see a slightly more female. Almost half were Spanish speaking. A little less than half had been born outside the U.S., mostly in Mexico. And current employment rates were very low. Look at the poverty, over 50% were at below the poverty level, and over 60% had either high school or less than high school education. And then our really exciting results to date. We're still tracking down a few patients for longer term follow-up, but as you can see, our control group is the blue and the intervention group is the orange. So actually having an advance directive in their medical record, tremendously successful, 32% versus 69%. It was hard to stay blinded once we looked at the medical records, because it was, we'd see Dr. Sidori's advance directive in the medical record, and we'd say, oh, okay, they're intervention group. We know this now. When we look at our specific form, no patients that were in the control group had our specific form. No one completed that form on their own and turned it in, not surprisingly. But more importantly than just that, having that document, is having those conversations. And so when we ask patients, have you spoken to your family about your future healthcare preferences? Over 80% of our intervention patients had, compared to a little over 50% of the control group. And again, looking at did you talk to your healthcare provider about what might be important to you? We're looking at almost 60% of patients had. Pain management. So these results are not statistically significant, and I take comfort in the fact that overall pain was very low across the board. So I'm gonna call this a floor effect, that we couldn't detect these differences, because really patients actually were fairly empowered in pain management, and they seemed to have very good pain control. In our quality of life, we did have a statistically significant difference in the physical symptom burden. And again, across the other aspects of quality of life, people had very, very high ratings. And the highest being 10, perfect. And you look at their existential and support, patients felt very, very supported. And then we asked them about their perspectives on hospice care. And remember that half of our population is Spanish speaking, and what hospice literally translates to within that community, and we made an impact. And I'm really excited to say that. We are looking at actual utilization now, and we've got 7 patients that we can't quite track down. So those results are pending still. But when you look at, would you recommend hospice for a loved one? There's a big differences. Would you recommend hospice for yourself? Would you think about hospice for yourself? Almost 90% of patients said that they would consider hospice for themselves in the future, when you compare that to about 65% in the control group. And so it is with great humility. I feel like I was part of a tremendous team, but we really thought of ourselves as a family of these wonderful navigators. And I'm happy to say that we do have the opportunity to move this work forward, and we're going to be looking at the same intervention, again, tailored to broader symptom management in a population of non-cancer Latinos in Colorado. So exciting. So more to come.